Welcome to this special edition of Time and Range, focusing on the ADA-EASD 2022 algorithm for the selection of medications for hyperglycemic management and the effect of those medications on time and range. I'm your host, Dr. Neil Skolnick, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, and joining us today is Dr. Joshua Neumiller, who is the vice chair and Alan I. White Distinguished Associate Professor of Pharmacology at the College of Pharmacy and Pharmaceutical Sciences at Washington State University. Josh, welcome.
Well, thanks so much for having me, Dr. Skolnick. I'm really excited to discuss this topic with you.
When we think about when to use medicines and when to add medicines, the first thing we need to think about, of course, is what is our goal in adding those medicines? And more than ever now, we have the opportunity to individualize our selection of medicines to meet patients' needs and specific goals. The old goal used to always only be glycemic control. In our new world, we have the opportunity to target different things, ranging from decreasing cardiovascular risk to heart failure to kidney disease to obesity to a lot of aspects that make things both better for patients but more complicated for us as clinicians. Glycemic goals, though, of course, are still important. So to start out, can you discuss the recommendations from the standard of care regarding glycemic goal setting? And particularly, can you, in addition to talking about A1C goal setting, talk about CGM, continuous glucose monitoring, and the metrics that inform us?
Yeah, thank you. Happy to do that. And I think you hit the nail on the head. This is the treatment of diabetes has advanced just so rapidly. It takes a lot to keep up with all the new data that's coming out all the time, and certainly CGM plays such an important role now. And I really think one of the most impactful advances in diabetes management, in fact, in recent years, has been the expanded use of CGM, not only in people with type 1 diabetes, but also in people with type 2. And CGM has certainly been a game changer for many of the people I work with in the home care setting who struggle with managing dramatic swings in their blood glucose. And starting these people on CGM can be incredibly helpful, particularly in people who struggle with frequent or severe hypos, many of whom also have some degree of hypoglycemia unawareness. And so to circle back to your question, we've seen an important shift over the last few years in the guidelines from a strong emphasis on assessing glycemic control through using A1C to now acknowledging that glycemic control can be assessed using A1C as well as other glycemic measurements, including use of continuous glucose monitoring to assess time and range, and also to calculate a GMI or glucose management indicator, which is essentially a CGM-derived version of an A1C. And what I think is so powerful with CGM is that it tells us so much more about the quality of an individual's glycemic control by allowing us to visualize highs and lows over time. And this is really in contrast to relying solely on an A1C, which gives us an average, but doesn't really tell us much about any glycemic variability, highs and lows that a person may experience throughout the day.
So when we think about time and range and glycemic variability, how do we goal set there?
Yeah, and as with every goal setting in diabetes, certainly the guidelines say we should individualize that. In general, time and range, we consider that between the amount of time spent between 70 and 180. We'd like to see that above 70% of the day or measurements that are gathered by the CGM. And certainly the less time spent below that in hypoglycemia and above that, the better. Those goals can be a little bit tighter in people, especially who are during pregnancy or people with type 1 diabetes preparing for pregnancy. Like to see that time and range a little tighter. And the target range can change a little bit. And conversely, we might loosen that up in older adults, as an example, who may have hypoglycemia issues or live alone, and we're worried about associated morbidity and mortality.
That's a really good point. I take care of a lot of elderly individuals, and I guess the general recommendations are not to have more than 5% of our time in a hypoglycemic range. I think there it's defined. Is it under 70 when they're using that definition?
Yeah, yeah, below
And
70.
for that older group, we might even keep them up less than that because the consequences of a hypoglycemic event in someone who's 70 or 80, if they were to fall because of imbalance or weakness and fracture a hip, is very different than the consequences in a younger person. You used the term, Josh, quality of control, which I think is a beautiful description. Can you say a little more about that?
Yeah, thanks. And I we always think about A1C, and we all have it ingrained in our minds that ideally we like to see people with an A1C less than 7%. But something to think about is that's just an average. And so you can have somebody with an A1C of 7 who is very tight control, and they're not having many spikes above 180, and they have infrequent or never have hypoglycemia. And conversely, because it is just an average, we can have somebody else who has an A1C of 7 who gets a gold star. But when you put them on a CGM, for example, you see that they're having spikes during the day up in the 200s potentially with frequent hypoglycemia, and things just average out to an A1C of about 7. And so I think really contextualizing our A1C or GMI, if we're using a CGM to look at that, and really, putting that in context of that, what I would call quality, how much variability are they experiencing throughout the day?
That's a really great point. It reminds me of a story I once heard about a statistician who drowned in a river with a mean depth of 3 feet.
Right.
Let's go on now and talk about medicines. When we look at our new algorithm, what's the first step after lifestyle modification in deciding what medication to recommend to a patient?
Yeah, certainly. So after lifestyle modification, the 2022 ADA-EASD algorithm highlights two key goals that really direct rather our selection of glucose-lowering therapies to meet a person's individualized goals. That includes adding agents with evidence of cardiovascular or kidney benefit in people who are at risk, really to mitigate their heart and kidney risk. And the second main goal is adding agents to achieve and maintain glycemic and weight management goals. I think it's important to note that these goals are not mutually exclusive, and we can often address both when appropriate when establishing an individualized management approach. I mentioned earlier that one of the most important recent advancements in diabetes management has been the expanded use of CGM. I would say the other big one on my list is our shift from a glucocentric approach, as you mentioned, to a management approach in type 2 diabetes that stresses heart and kidney protection, based on all we've learned and continue to learn from cardiovascular, heart failure, and kidney outcome trials. Yeah, so with regard to cardiorenal risk reduction, the algorithm stresses the addition of agents with evidence of benefit specifically from the GLP-1 receptor agonists and SGLT2 inhibitor classes currently. For people who are high risk or have established ASCVD, the guideline recommends the addition of GLP-1s or SGLT2 inhibitors. The guideline does not give a preference for one class over the other, really based on the absence of head-to-head trials evaluating these two classes and their benefits on ASCVD. In people with comorbid heart failure, SGLT2 inhibitors are recommended. Strong evidence in people with heart failure, including people without diabetes in many of these heart failure trials. And then in people with type 2 diabetes and chronic kidney disease, SGLT2 inhibitors are now considered standard of care in those individuals due to evidence supporting their use in preventing progression of kidney disease and certainly progression to important outcomes in our patients, such as progression to requiring dialysis and kidney replacement therapy.
Now, in the current guidelines for people with chronic kidney disease, do they have to have that high level of albuminuria to opt in for an SGLT2?
Yeah, it's a great question, and it's one that is actually there's been a little bit of confusion depending on which guidelines you look at. So some of the earlier kidney outcome trials with canagliflozin and dapagliflozin, their inclusion criteria included primarily people who had that elevated albuminuria. Some of the meta-analyses and evaluation of the broader evidence has suggested that even people with low or normal albuminuria still seem to derive benefit with SGLT2 inhibitors. So the ADA and KDIGO, which is Kidney Disease Improving Global Outcomes, published recently a consensus statement, and they've taken the stance that we should, whether people have albuminuria or not, if they have chronic kidney disease, we should be using SGLT2 inhibitors in those individuals to improve outcomes.
That's really helpful. And let me ask you a question that I've heard a number of my colleagues ask, which has to do with metformin. It used to be something we didn't think about at all. If you had diabetes, first step was metformin and then a decision about next medicines. But now, if someone has one of the things that you said, ASCVD, high risk for such, heart failure, CKD, do they have to be on metformin first before benefiting from the other medicines?
Yeah, great question, and certainly one that's been somewhat of a point of debate in recent years. And I've attended some along those lines, some great debates at the big ADA meetings and some of the endocrine meetings about that. When this evidence first was coming out, the vast majority of individuals in these outcome trials were on background metformin. As our evidence base has grown and folks have been able to look at the various trials in aggregate and really look at those individuals who weren't on background metformin, evidence suggests that those individuals still derive benefit. So it's a benefit independent of background metformin therapy. And so the guidelines have really evolved with that evidence. And now, if somebody at the time of diagnosis of type 2 diabetes has some of these, if you will, compelling indications, the thought there is not to delay addition of these medications that have very important risk reducing properties, and in many of these trials prevented death. And so the guidelines say that we should add these on, and I think certainly we could consider down the line or concurrently the role of metformin to help with meeting glycemic
Yeah.
targets as well.
That's so helpful. And you mentioned glycemic targets. If someone is ready to go, that person with an A1C of 6.9, 55-year-old guy, a history of, we're going to talk about someone with the TIA in a minute, but before that, if someone's ready to goal, can they still benefit from either the GLP-1s or SGLT2s if they have an indication?
Yeah, so the data suggests they do. And so again, when they've looked at folks in these outcome trials whose A1Cs were in what we would consider a good or target range, those individuals derive cardiovascular and mortality benefits as well. So important point, these guidelines, we have those two concurrent goals: cardiorenal risk reduction and optimization of glycemic and weight management. And recommendations say that anytime these ASCVD, heart failure, kidney disease become a clinical issue in somebody with type 2 diabetes, we should be thinking about adding these agents on, irrespective of what their current level of glycemic control is and irrespective of their background diabetes regimen.
Really big changes. Now, Josh, since many of our patients are already on multiple medications before we had these guidelines, can I ask you how you might approach what's really a fairly common case? Let's say a patient who is 70 years old with type 2 diabetes, hypertension, hyperlipidemia, and has a history of a TIA 2 years ago. He's currently on lisinopril for his blood pressure. Blood pressure is well controlled. For glycemic management, he's on metformin 1,000 twice a day and glipizide 10 milligrams once daily. He has normal renal function, and his most recent A1C, done a week before the visit that we're now seeing him at, was 7.2. Not bad. But with this history of TIA, and he's on metformin and glipizide, how do you approach this?
Yeah, thanks. And I agree. I think this is a pretty common scenario that would come up in many of our practices. Some key things here. I mean, this individual does have that risk factor, TIA several years ago. So going back to the algorithm, falling into that ASCVD category, I would be thinking about we should be getting this person on either a GLP-1 receptor agonist or SGLT2 inhibitor for cardiovascular or cerebrovascular risk reduction. I'd probably be leaning towards GLP-1 receptor agonists in this case. The data with regard to stroke and et cetera seems to be a little bit better with that medication class, at least with current data. And some of the stroke guidelines are actually starting to incorporate GLP-1 receptor agonists as an intervention as well. But looking at the algorithm, both would be appropriate. But I would be leaning more towards GLP-1. I don't know about you, Dr.
Oh,
Skolnick.
I agree with you. It's one of the not as well recognized things that I'm really glad we've had a chance to discuss that the SGLT2 trials didn't, in their MACE endpoints, stroke wasn't one of the ones that showed a benefit. In the GLP-1s, stroke in every one of the trials showed was on the right side of that forest plot. And so in the recent, I think it was a year and a half ago, American Heart Association, American Stroke Association guidelines, they do, as you said, recommend a GLP-1. This is an interesting patient because he's almost to goal, not quite to goal. We're thinking about adding a medicine. And I always get, even though I know a GLP-1 shouldn't cause hypoglycemia, I get a little worried. And as I say that, I recognize he's on glipizide, so the GLP-1 might not be causing the hypoglycemia, but if his baseline is brought low, he might get hypoglycemic from the glipizide. So I'd probably stop the glipizide and add a GLP-1. Josh, your thoughts?
Yeah, that would be what I would definitely be leaning toward. Some of the commentaries in the literature, a lot of this is empiric, but some of them say if somebody's A1C is less than 8.5, cut the background sulfonylurea or insulin in half. This person's is 7.2. Going back to our time and range discussion and glycemic goal setting, it'd be interesting if this person was on a CGM to see really what's going on. Is he a little bit above that 7% mark due to some postprandial excursions? How's his fasting? My suspicion is, depending on which GLP-1 receptor agonist we went with, even with getting them off the glipizide, they're so efficacious in terms of glycemic lowering. I would suspect that we could probably get this person to goal with removal of the glipizide after we titrate the GLP-1, and probably he'd do a little bit better with regard to any hypoglycemia he may be currently experiencing.
Sounds good. I agree. Let's go on now with our algorithm or discussion of the algorithm. So as we've talked about the one side of the algorithm, ASCVD, high risk for heart failure and CKD, we've covered that part. How about if someone doesn't fit into those categories? What are the recommendations?
Yeah, so if we can remove the need for cardiorenal risk reduction from the table, and that's not a factor, the guidelines stress really focusing on achieving individualized glycemic and weight management goals. So for glucose lowering, the guideline recommends use of metformin and other glucose lowering therapies, either alone or even in early combination, that will provide adequate efficacy to achieve that person's glycemic targets and goals. And choosing agents with a low risk for hypoglycemia is also stressed, particularly in individuals who are high risk for hypoglycemia. And then concurrently, the guideline emphasizes establishing weight management goals and implementing appropriate lifestyle interventions, and also considering the impact of our glucose lowering therapies on weight. The guidelines also acknowledge that we should be thinking about potentially adding on medications indicated for the treatment of obesity, and even considering metabolic surgery when appropriate and indicated. So those have worked their way into that algorithm as well. And of course, we can often, I would say, do a lot, however, for our patients who do have overweight or obesity by added addition of GLP-1 receptor agonists, as we've talked a little bit about today. And then we also have our recently approved dual GLP-1 GIP receptor agonist tirzepatide, and the weight loss data with that agent is very impressive. And I've seen some dramatic weight loss in the few people I've seen on that medication. I don't know what your experience is, Dr. Skolnick.
Yeah, I have too. I did not think that I would ever see more weight loss than we saw with the potent GLP-1s. And now we have the dual GLP-1 GIP receptor agonist tirzepatide. And it's amazing. And the weight loss happens quickly. In the large trial in June in the New England Journal, and people with obesity without diabetes, that group achieved 22% weight loss. I mean, they started with an average weight of, I think it was 235 pounds, and they lost on the average over 50 pounds.
It's
It's
incredible.
amazing. Yeah.
Yeah.
The power of these agents for weight management is pretty amazing. And it makes me reflect, and Josh, both you and I have been practicing for a while. It wasn't that long ago, it seems like a long time ago, where we would put someone on sulfonylurea when they came in, and that makes them gain weight. Or if someone was quite uncontrolled, we still start with insulin. But I think one of the things that this algorithm makes me think of is you might start with insulin to bring down that glucose toxicity, but you don't have to stay there. You can switch out to a medicine that doesn't cause weight gain. Insulin causes what, around 10 pounds of weight gain that first year when you put someone with type 2 on it.
Yeah, important points. And, I always struggled a bit with, I'd be educating people about the importance of losing weight, and then we're adding on a sulfonylurea, and, our actions don't match our words and advice. That's working against them. So it's great to have these agents where we can not only dramatically improve glycemic control, but help with that weight as well.
Yeah, and with that in mind, let's go over another case. 42-year-old male diagnosed with type 2 diabetes 2 years ago, on atorvastatin for cholesterol management and on insulin glargine 20 units daily for blood sugar control. He has a BMI of 33 and an A1C of 8. How would you approach this person?
Yeah, it's an interesting case, and one where, if we did have CGM data in this individual, it would tell us a lot. He has an A1C of 8%. I would suspect he could probably benefit from additional fasting glucose reduction. So maybe we would need to up titrate that insulin glargine a little bit to achieve that. But he probably also experiences some after meal glucose spikes that are contributing to that. So I'd be interested in learning a little bit more about how this person got where he is. Has he tried other agents? Did he fail metformin? Has he tried other meds? Why is he being managed with glargine monotherapy? I'd also want to ensure he didn't have any of those compelling indications we talked about, ASCVD, heart failure, or kidney disease, which would dictate potentially our next steps. But we do know he has obesity based on his BMI. His A1C's 8%, which I would imagine 42-year-old person, we'd want him below 7% if we can do so safely. And, he could benefit from weight loss and improved glycemic control. So I think if we went back to the ADA EASD algorithm, it actually has another figure within that paper that specifically addresses insulin use in people with type 2 diabetes. That algorithm encourages continued use of background metformin, SGLT2 inhibitors, and GLP-1 RAs when starting insulin to mitigate insulin-induced weight gain and to decrease the amount of insulin required to achieve glycemic goals. Our patient doesn't appear to be on any of these, but the algorithm also states that when the fasting glucose is at goal, but the A1C and time and range, so specifically also addresses time and range are not a goal, consider the addition of a GLP-1 receptor agonist if they're not already on one, to help address those postprandial spikes. And I would say this person, that would what I would initially be thinking about, pending additional information about his history and the like.
Yeah, it's interesting. That's what I was thinking, that I'd probably, in my practice, I would probably try to be bold. And I'd probably cut his insulin in half, add a GLP-1. Ideally, if he could have a CGM and he's on insulin, insurance should pay for that. Put a CGM on and then bring him back over a shorter rather than longer period of time, sometime in the next 2, at the most 4 weeks, and see how he's doing, with the goal of hopefully maybe even being able to get him off of insulin. I've seen a number of people who have been started on insulin because they're taken care of by someone who grew up in an era where insulin was what they became comfortable using. And that's what they never got them off the insulin. So that would probably be the way that I'd approach this.
Yeah, and I think you brought up an important point about backing off that insulin when adding it on. Again, as we talked about in the case of sulfonylurea background therapy, really avoiding those hypoglycemic events.
So as we're getting toward the end of our podcast, I want to think for a minute about which medicines are really important to use CGM when we have people on, and which they're kind of optional and would add a lot. We learn a lot from it, but how do you decide when and who to use CGM with?
Yeah, so people who I think I really lean towards CGM and recommend CGM use, certainly if they're on any agents that put them at risk for hypoglycemia. So as you mentioned, really anybody on insulin, including older adults on basal insulin, especially when they're using it in combination with sulfonylureas. And some of the people I work with, they can't afford some of these newer agents, and access is an issue. We've talked a lot about GLP-1s and all their benefits, but some folks have access issues, and so if possible, to get them on CGM because they are on background insulin therapy, it can just do so much. At the front end of our discussion, we talked about really adjusting goals, especially in some of those older folks who may be at risk for hypoglycemia. And setting those thresholds and alarms with our CGM so that people can act when their blood sugars are higher than 70 can be so impactful. If people are on other regimens where hypoglycemia risk is low, combinations of metformin, GLP-1s, and SGLT2 inhibitors, as you said, can tell us a lot about how to fine tune moving forward, but less important from a safety standpoint, I would say.
Yeah, I agree. There, I'll really ask a patient, or often the patient will ask me because it's advertised now a lot, if it would be useful. And I think its biggest use when you're on a medicine that doesn't cause hypoglycemia is that feedback loop that you get. You
Right.
see the results in short order of your dietary choices, and I've seen many epiphanies occur on a regular basis. Josh, this has been so helpful. Do you have any last thoughts for our listeners before we bring this podcast to a close?
Gosh, I would just reinforce a lot of what we've been talking about. Our guidelines have changed very quickly over the last 5 years or so to acknowledge the power of CGM and time and range, and also to emphasize the importance of using agents with evidence of heart and kidney benefit. We know there's a gap right now with optimizing use of these therapies in folks. So really just encourage listeners to utilize these tools whenever possible, because they can truly make a huge difference in improving outcomes as well as quality of life for our folks living with diabetes.
This was so helpful, Dr. Joshua Newmiller. Thank you for joining us and sharing your experience.
Well, thank you for having me, and I really enjoyed it. Thanks so much.
Josh, we really enjoyed having you. We want to thank our sponsors, Abbott and LifeScan, for sponsoring this episode. This is critically important information that enables us to do more and more for our patients and helps us to tailor our recommendations both with regard to medications and monitoring to our patients' individual needs. For more information on time and range, ADA's 2022 Standards of Care, and additional resources, please visit professional.diabetes.org/time and range. For the American Diabetes Association, I'm Dr. Neil Skolnick. Till next time, stay safe and keep learning.